Good afternoon, everyone. Welcome to today's research conference. It's a real pleasure today to introduce Janet Prvu Bettger, who's an associate professor in the School of Nursing. She's also a health services researcher and works collaboratively across the campus here at the DCRI, Duke Global Health Institute, and has a number of very active, interesting programs that we'll hear a little bit about today. This pairs very well with last week's conference and in highlighting the use of technology for providing better healthcare to our patients. Janet's background, she got her bachelor's at the University of Western Ontario in Canada, and then went on to get a Master's of Science at the University of Wisconsin-La Crosse, prior to doctoral training in rehabilitation sciences at Boston University, and then a postdoctoral training at the University of Pennsylvania through an NIH NRSA research fellowship in neuro rehab, as well as a research fellowship with the new Cortland Center for Transitions in Health, and a Schweitzer Fellowship funded by the National Institute on Disability and Rehabilitation Research to study the role of the environment on functional outcomes. She's got a very interesting research program dedicated to improving healthcare quality and care coordination for older adults with chronic conditions, particularly for stroke and those with functional decline requiring rehospitalization. She's the PI in a PCORI grant to study the comparative effectiveness of various treatments for stroke and rehab, as well as a number of implementation research studies on transitional care for stroke, including COMPASS, a pragmatic trial in North Carolina funded by PCORI, Transitional Care Healthcare Quality Collaborative in Ohio, funded by the CDC, and the RECOVER trial in China. Please join me in welcoming Janet today.
So thanks for having me here today, and thanks for being here. This is a really exciting time for a significant component of healthcare that has such broad capacity and has the potential to dramatically affect patient outcomes, but really doesn't get the attention that it could. I have gotten the attention of the director of the DCRI, so I figure if I can excite him with this topic, I'm hoping to excite you guys about it today as well. The concept of rehabilitation, I think, is something that creates different images for different people, partly because of your own experience and maybe in part from where it has crossed your life. So for example, if you have needed a hand therapist, or you've gone to see a physical therapist for something, maybe someone in your family has gone to a skilled nursing facility, you may have a perception of rehabilitation. It's painful, whether it works or not, how much it costs. Maybe you didn't continue in that care for any of those reasons, that it hurt, cost too much, or whatever else it might be. Maybe it was inconvenient. But what I really want you to focus on today is an enhanced perception of rehabilitation from a multidisciplinary perspective. I want to talk with you about rehabilitation today in an area that when we consider rehabilitation, we're really focusing on restoring function. This was a Wordle created of all the definitions, the disciplines that are involved in rehab, but the focus not being on any one body part, but instead thinking about the whole person, working with that person in a comprehensive program, and trying to essentially put the pieces of that person's life back together from a medical, social, emotional, vocational perspectives after an injury or illness. The goal seems so simple: functional independence, and how to best attain quality of life and what that means for that person. Seems simple, quite complex. In the US, when we talk about rehabilitation services, these are organized and defined more by how they're paid for. And so I wanted to start with this description because I'll be referring back to these terms quite frequently. So on the lower left, you see a reference to the term PAC. Because of the way services are paid for, we're going to talk about PAC being post-acute care. Rehabilitation being provided in primarily 3 inpatient settings: inpatient rehabilitation, skilled nursing facilities, and long-term acute care hospitals. And then in the community for people discharged home, either provided in the home or in outpatient care. What becomes so important is that our best estimates right now of utilization are from Medicare data, and we know that about 1/3 of Medicare beneficiaries are discharged home to receive some type of post-acute care or rehabilitation. What's so significant and why I come to you today from a perspective of stroke and talking about rehabilitation is that we have more than 2/3 of stroke patients being discharged to receive post-acute care. Stroke is an ideal population to study rehabilitation, to push the agenda forward on policy, on practice, and on research. And here we have an amazing distribution that we can be able to look at in over 1 million patients every year in the services they receive and how to be able to promote functional independence. So the focus of today's talk is going to take two different sides. I really want to spend some time first talking with you up front about stroke and disability rehab and the gaps where we've been and kind of our perspectives of the field. And then talk with you about the changing landscape and about the work that's being led from here, from Duke, and in collaboration with others. We've seen stroke mortality decline over the last few decades. And just before the new year, we were really excited to learn that stroke is now the 5th leading cause of death, not 4th, not 3rd, now the 5th leading cause of death. But what's sad for me is that I've been in this field for almost 20 years, and I continue to use this slide and just update the map. Stroke continues to be the leading cause of disability in this country, and most recently is now the 2nd leading cause of disability worldwide. When we can look at numbers globally, we know that there are more people having a first ever stroke, but more people are surviving them, which means we have a dramatic increase in the number of people surviving a stroke with deficits that aren't most often being addressed, and we don't have the services or resources to support them. In a nutshell, when I talk about disability and impairment from, at least from this country, we know that about 3 of every 4 stroke patients or survivors have some level of dependence for something related to self-care. They need help to be able to make it through their day. And over 60% have cognitive impairment. Huge implications for safety and independence at home. And these are not being addressed right now in the system we have. We have 1/3 of stroke patients experiencing post-stroke depression, also not resourced, at least in this country, to be able to meet those needs. I started in this field and moved to the US just after TPA was approved by the FDA. A really exciting time in stroke care. I came here with such hope in being able to think about care redesign, how do we be able to engage teams across the system to be able to think about better outcomes for stroke patients. And we moved quick into the space of being able to educate and teach people how to recognize a stroke. What does this look like? There was so much focus on this acute recognition and getting people into the hospital, but yet really no increased attention to rehab and recovery. It was always implied, come in early, we can get you in for treatment. But not the, if you don't get there in time and you're not eligible or we aren't able to treat you, you're likely to have significant disability or impairment afterwards. Care redesign efforts, the registries that were designed, regulations that came from that period from 1997 through about 2003, a dramatic time for stroke and change, really fell short. We spent a lot of effort, and it was really exciting to see the efforts in mobilizing the pre-hospital to hospital arena, really being able to invest in measurement and quality. We started Get With The Guidelines in 2003, and again, measurement stops at hospital discharge. A tremendous gap in wanting to understand what happens after hospital discharge, where the average length of stay is only 4 days, and yet we have the rest of these people's lives to be thinking about. So what I want to do is invite a friend of mine up here to speak and have you give her perspective of what happened from 2000 or after 2003 to today.
Thank you. I had to write everything down because I am a bit of a talker and I had to keep myself on track. But I've always been a talker. In high school, I was in charge of set design for 3 years. It was a very artistic school, and I was in charge of directing 30 to 40 kids at a time coming together in one end project. That carried over into college, where I was a broadcast communications major with an interest in sports production. I was on the debate team, an officer in my sorority, and I went to Elon, so I was a member of the inaugural Elon poll. So as part of that, I had to cold call people all over the United States and ask them about politics. It was good times. So my supervisor with the Elon poll once described me as being able to talk to a wall and then getting in a full-blown conversation with it. After graduation, I worked at a company in Raleigh doing online marketing with a lot of client interaction on the telephone. One day, my supervisor at the time, my HR manager, and I all decided that we were going to go see Harry Potter 3 on the day it came out. Well, I did actually see the movie, but it was about a month later. I started having difficulty with my speech. I felt weakness in my arm. And my coworkers were afraid that I was having an allergic reaction because we had just eaten at a new place. So they drove me to a hospital. I was at the emergency room within 30 minutes of my first symptom. This was June 4th, 2004. The hospital I was at had TPA at the time, but the emergency team, as a young person coming in with young friends, thought I was having a reaction to street drugs, which I've never done before in my entire life. But with my slurred speech and balance difficulties, I wasn't a great historian in their mind. So I don't really remember a lot about my first few days in the hospital. I was diagnosed with having 2 strokes 12 hours after coming in the hospital, which was well outside the window for TPA. I had no family history of stroke. I didn't have any risk factors, but I had trouble speaking all of a sudden, and my right side was weak. I stayed in their critical care unit for 3 days and then was moved to a medicine floor. What sticks out really strongly in my mind, even at the time and all these years later, was that the materials I was given to educate myself and my family about stroke, it was a binder. On the cover of the binder was 3 pictures. On the right, an old lady with white hair. On the left, an old man with a walker. In the center, an older couple sitting on a park bench. Now, I'm sure it contained a lot of good information, but it was really small print, and I was having trouble focusing. Also, was that going to be my life, sitting on a park bench at 23 with white hair? So I was offered to go into a rehab, an acute care rehab. But in my mind, a rehab was a nursing home. And I've always been a fan of the Golden Girls, and I was not going to Shady Pines. They offered me the chance to go into rehab several times. And again, I kept saying, no, I want to go home, I want to go home. And then after the 4th day, I was able to walk 200 feet with the therapist by my side. I no longer qualified. It was many years later that I actually realized that I should have jumped at the chance to go into rehab. I wouldn't have had a long like this day because physically I was getting so much better. But myself and my family could have really benefited from the education and the stroke professionals, the rehab professionals that I would have worked with. I had to deal with a lot of things on my own that I just didn't understand. I was emotional all the time, crying at the drop of a hat. I didn't have a long attention span. I had trouble focusing my eyes. I still have neurogenic pain. My husband said I was a different person. So less than a year later, we were separated. I also lost my job. I tried to go back to work within 6 weeks of having my stroke, and it was way too early. Even though I only went back part-time, I just didn't have the energy and the focus in order to be able to do my job. So as I was thinking to myself, I lost my marriage, I lost my job, what I was going to do next, I decided I really wanted to help people who had had a stroke, young people. And as I was researching what I could do, physical therapy, occupational therapy, or speech therapy, I thought to myself, well, I'm not very good at science, so PT and OT are out. Speech is a lot of science. But at the same time, I realized that my speech therapists, the different ones I worked with, outpatient and in the hospital, they were the ones who helped me regain my identity the most. So I looked at the schools, and I ended up going to Appalachian State in Boone. And my first class on campus, my neuroanatomy professor passed out note cards, writing down why you were interested in speech therapy, little bits about you, and I wrote down, I had a stroke. So he comes up to me after the class and asked me if I would be willing to talk about my experiences with the class when we got to our stroke unit. Of course, I agreed. And when I went and spoke about that to them a couple of months later, I realized it was the first time I had spoken in public in 5 years since I had had my stroke. And it was such a big part of my life before that. So fast forward to now. Sorry. After I graduated, I started working at Duke Regional, and I work in both their acute rehab department and in the acute care hospital. We cover both settings. Our physical therapists and occupational therapists are great, but they tend to be focused either on rehab or acute care. And I think the way our department is set up, the speech department, covering both, we actually get a really good picture of a person as a whole in their treatment. So a patient might be able to walk 500 feet, but then we think, well, we just went in and saw them right after physical therapy, but could they remember to tell me that they walked 500 feet when I asked them what they had done with physical therapy not 5-10 minutes ago? Are they actually oriented, knowing what happened, where they are, or can they answer questions very well by looking at the whiteboard in their room with that information written on it? And believe they can go out and drive a car, but they're actually ignoring everything that happens on the left side of their world. So there's so much a speech therapist can do to help these patients and train their families about why a person can't or shouldn't be left alone, even if they can walk and get out of bed and get to the bathroom on their own. But a patient's physical needs still determine so much about the type and length of rehab that they can get. And that is what they use still to qualify people rather than their cognition or their language needs. And in speech therapy, one of the things we often focus on is allowing them to do these things even if they're going to need help physically, but allow them to maintain as much independence as possible and train their families to do that in a safe and controlled environment. Because how else would they know? In their minds, unless they've experienced it, mom had a stroke or grandma had a stroke and she ended up in a nursing home. Stroke is still thought of as something that only happens to older people. The American Stroke Association considers a young person's stroke to be anybody under the age of 55. I'm sorry, but at 23, I was in a much different state of my life than somebody who was 53. We have to consider things like returning to work, socialization, raising your children, maintaining a romantic relationship. And of course, they're important for all patients, but in your 20s or even in your 30s, you're just starting out. When we do get our younger stroke patients at our acute rehab center, a lot of times their physical deficits are so profound that they may never be able to return to work at 30 or 40 years of age. But we can still help with socialization and helping them feel more normal. And education for the patient themselves, the caregivers, and their families. Unfortunately, I find myself encouraging physical therapy and occupational therapy to kind of find reasons for their more mobile patients to qualify for home health services. Maybe it's to adapt to living at home because they're much more likely to be able to follow up with a consistent speech therapist 2 or 3 times a week rather than getting into the outpatient setting. Our outpatient clinics, unfortunately, tend to be overbooked and overworked, especially for our older patients. And once they get into that setting, it's very hard to get a consistent follow-up. So in the future, I can see need for much more therapists trained in how to integrate people back into society from all the disciplines, considering all the things that we need to do to return to work, to return to our lives. And I have a feeling that technology is going to become very important in those areas by use of the applications in therapy and then training family to use it to continue progress after they leave. And I'm excited to see where that goes because I feel things are moving in that direction, and I just hope to help everybody bring that forward.
For me, I'm almost 20 years into this work, and I think just this last year, I became excited at where we were going, because it was finally as though we had the momentum and people invested in wanting to push these agendas forward. And as Chris mentioned, it largely comes from how we're making decisions in acute care, the gaps we still have in the community, and how we kind of conceptualize stroke, that this isn't just affecting older adults. So the road forward. I want to focus first on the work that's funded by Prvu and some of the analysis we're doing in comparative effectiveness to really understand the first services people receive after they're in the hospital. So what we had promised to do was generate evidence really around this critical decision at hospital discharge. We have almost 1 million times every year to be able to make this decision with families just in stroke, but I know that you're doing it with all the populations you work with in cardiology and with orthopedics. And I think we need to give this more thought. Do we actually know where we're discharging these patients to? Is that the optimal place for their recovery? So we're studying the comparative benefits and harms of the most prominent services after discharge, and we do have the need to be able to disseminate these findings clearly to the right targets. When we first looked at patterns of care, we were quickly reminded, of course, that an acute hospital stay is about 4 days, and yet we have an episode of care that lasts almost 100. So what are we doing after those 4 days? We have almost 80% of stroke survivors bouncing through the system, multiple care transitions, going from one service to another. There were over 3,000 unique patterns in a patient sample of 150,000. 3,000 unique patterns in 120 days. How do we possibly study the comparison of those? So we started in the beginning. We wanted to know where they started, and we have almost an even split. About half of our stroke patients are going home, and about half are going on to continue inpatient care. A really, what seems like a really clean comparison from the beginning. But these two populations are very different, the ones that go home and the ones that don't. Of the ones that go home, NIH stroke scale is an indication of stroke severity. You know, they have a lower stroke severity score, pretty much median of 3 across the board for those going home. And so we couldn't compare home versus inpatient. It wasn't something we could do, at least in this country. And so we started first comparing inpatient settings. This ended up being such an important question for policymakers because right now they're trying to decide, should these two services be paid for differently? Does it really matter where we send patients? Are they different? Are services any better in one place or the other for stroke, for orthopedic, for COPD? And we don't know. We don't have the evidence. On a practice level, the settings are very different. So for me, from a rehab perspective, it was mind-blowing to even think that we would want a level payment between these two settings. We have a very different level of engagement of therapy in inpatient rehab versus skilled nursing. Physician engagement, very different. Nursing as well. In some of these skilled nursing facilities, we don't even have nurses on the floor most hours of the day. Length of stay is different, regulations are different. But yet we discharge to them pretty evenly. So 2 aims first out of this study, but ultimately we wanted to compare the benefits of the two, benefits and harms of the two. I learned really quickly in working with some really smart statisticians in this building that we needed to have the two samples comparable. And there are some things that just make these samples not comparable. People who were receiving comfort care measures only in the hospital, people who had metastatic cancer, long lengths of stay, all sorts of things. We removed them from the sample. If they had an indication for hospice, they weren't likely to even be considered for intense rehab. So we removed them from the sample and ultimately had about 69,000 patients that we could study using data from Get With The Guidelines, AVAIL, a longitudinal registry, and connection with Medicare claims. This particular one does not include the AVAIL data. So almost even distribution between the two groups. And still we saw that the patients going to skilled nursing facility, as those of you that discharge patients we know, are sicker. They're older, more of them were female. They had higher health service use before that acute hospitalization, more severe strokes, and a longer length of hospital stay. Now, what was really interesting in being able to decide and position this with funders of how we would get at this question best when we couldn't randomize patients to one or the other. So using existing data, there are certain things that we know and that we have measured. We know stroke severity, we know their physical function, we know all of these patients were Medicare fee-for-service, and we knew that the facilities were available and we had the distribution of those. But in these data, there are certain things that we don't know. And these unmeasured confounders were very problematic and concerned a lot of people. We don't have patient and caregiver preference, and you know that's a really important part in trying to determine where people are going to go after the hospital. And Chris's story is a great example of that. Cognition, social support, bed availability. We don't have, was a bed actually available on the day that that family was trying to make this decision? So we used a method called instrumental variables. Many of you are familiar with this and have been engaged in these discussions to estimate causal relationships. And we used two different ones, but the one I'm going to show you today at least, we used the distribution of the percent of patients that were discharged to an inpatient rehab facility. So practice patterns were our instrumental variable. And what did we learn? To orient you to how these data are presented, at the very top in the first clear white bar, we have just raw data. And we see that patients that are immediately discharged from the hospital to a skilled nursing facility, more of them have died by 14 days, by 90 days, and a year when compared to those that are discharged to an inpatient rehab facility. When we look at unadjusted in the next gray bar, so considering just the relationship between what service they got and death at those different time points, we see that if you go to an inpatient rehabilitation facility, there's a benefit. This is unadjusted. Using inverse probability weighting in the next white bar, so everything that we had, and we had a lot of data from Medicare claims and from Get With The Guidelines, so using inverse probability weighting of everything we measured, we still see a benefit for inpatient rehab on mortality. Using instrumental variables, so on the very last line at the bottom, although we see that this is attenuated a little bit, we still see a benefit here out to 1 year for mortality for patients that are discharged first to an inpatient rehabilitation facility. We also looked at readmissions, a really hot topic, of course, in our healthcare environment right now. These are raw data, and just independent of survival, slightly higher numbers for those patients that start out in a skilled nursing facility. When we look at the same kind of presentation of the data, we still see benefit for inpatient rehabilitation over skilled nursing facilities if you start there after your stroke for readmissions or death. So why is this so important? And why did I put this in the next era of rehabilitation science? This is the first comparative effectiveness study of rehabilitation that includes both clinical data and claims data. We haven't been able to do this, and most of the findings, well, all of the findings to date have just been based on claims data. We did show that the skilled nursing facility patients are different than inpatient rehab. And from a policy perspective, we had been hearing that no, when people leave the hospital, they look the same. And by leveraging Get With The Guidelines data, we showed that those two populations are different and need to be considered differently for these services at discharge. The risk of mortality in all-cause readmissions is lower for patients that went to inpatient rehab. And although we do this quite often in this building, using instrumental variables and different approaches to analyses, this is one of the first times this has been done in the area of rehabilitation. And depending on the approach, of course, we found slightly different findings, but ultimately we did find a benefit. So coming down the pike, many of you have been engaged in discussions around a methods paper that we want to be able to disseminate about this, being able to disseminate patient perspectives. A key question we're moving, and now the Centers for Disease Control has funding out in their Coverdell infrastructure. They've added on top of the work being done out of acute registries to also want to understand in that post-acute space who should follow a patient. Primary care and neurology. We don't have evidence for that either, and we'll be able to look at that in this study. And then we'll also be looking at outcomes after rehab for those that go home. This ends up being a big gap. We first looked at those that started in inpatient care, but what about the other 50% that go directly home? 50% of our population, almost 500,000 people a year that go directly home. And again, we don't have evidence to guide these decisions. It's at a time, as Chris was saying, where we haven't yet built the infrastructure to best support stroke patients and their families to recover in the community. Excuse me. So the second area, the second area I want to focus on with you today is on organized optimal care. And I think Upton made reference to this a little bit in the work that we're doing now in intervention space. We recognize that this is a critical intervention point when someone leaves the hospital. Critical. And we're doing very little in stroke here. We have great evidence in massing out of acute care around the world at this point, even in low and middle income countries. And then we send people home and say, good luck. Tremendous gap. And we really, it widens as we move outside of developed nations, but a tremendous space and an opportunity for us to do more. We know in other conditions, and many of you know in the spaces that you work in, that care transitions and poor care transitions lead to a lot of adverse events. And these can be prevented. And so the work that we actually started here from a systematic review gave us the first glimpse into what we did and didn't know. Transitional care is a set of actions, a set of strategies that we can implement as patients move across settings. In a nutshell, if we consider it from a service perspective, it's supposed to be time limited. It really is supposed to bridge that hospital to home gap. Focus on continuity. Most of these models are led by a nurse, and it is emerging as a key factor in care coordination. Particularly for the clinicians in the room, these models are highly promoted. Joint Commission, CMS, always leveraging the science behind these. Red out of Boston, Grace out of IUPUI, the transitional care model, Mary Naylor's out of UPenn. The care transitions pillars is Eric Coleman's. Boost is the Society of Hospital Medicine. I mean, these are just promoted as the science we need to be using to moving the field forward in preventing readmissions and adverse events after hospital care. But you know what? Very few of these included stroke patients. Very few. And of the ones that did, they weren't powered to be able to tell us would they actually work for stroke. Stroke is so complex. The needs around physical and cognitive function are often not addressed in these models. And they don't even include rehab professionals on their teams. When we did the evidence review out of the Evidence-Based Practice Center here, we couldn't include any of those broadly promoted models because they didn't include stroke. What we did find was the literature out of the UK and out of Australia promoting a model called early supported discharge. Again, around that frame of transitional care, but highly integrated rehabilitation to be able to understand and best support functional needs. So here we have 2010 health reform. We had a wave of policy that moved forward around transitional care, readmissions penalties. The Centers for Disease Control commissioned this systematic review to want to find out, okay, if stroke's up next for these readmissions penalties, what can we be doing for these stroke patients? We completed the review, and as we started to disseminate this internationally, realized quickly there's work happening in this space, but it really isn't being studied well. The Centers for Disease Control then funded 3 states to begin to test translation of individual strategies, Ohio, Michigan, and Massachusetts. So I'm the transitions and care specialist for the state of Ohio, and what we started to do was pull together who we needed to at a state level to think about what could we do and who should we leverage in this discussion. And we led a learning collaborative framed around like the Institute for Healthcare Improvement's Breakthrough Collaborative Series on being able to move forward certain metrics from hospital to home. And just a snapshot of where that went, by 2014 at the end of that collaborative, we had 93% of the hospitals at least assessing patients' needs and had redesigned their teams, which is difficult to do in stroke teams that aren't funded, but redesign their teams to actually have dedicated people to address the care coordination needs of these patients. We focused on such things as setting appointments for patients before they went home. would you have thought that we're sending patients home without appointments to see somebody after they've left the hospital? It was almost expected. I mean, these teams just thought, well, somebody must be setting these appointments. And when they actually looked at their discharge summaries, there weren't any. No recommendations for follow-up. And so this was one of the metrics that we pushed forward using the heart failure metric for physician follow-up. We tested this for stroke. Still a significant amount of work to do, but progress is being made. So we were able to test this in these 3 states, and leveraging what we were finding in our PCORI-funded study for comparative effectiveness for rehab, leveraging what we learned, what we're learning out of the registries like Coverdell and Get With The Guidelines, and what we were learning from the CDC-funded states for care transitions. We pulled together this information together last summer in a proposal to PCORI for a pragmatic clinical trial for transitions of care and early supported discharge. We were funded, as Ethel said. So next Friday, we start a pragmatic trial here in North Carolina, a cluster randomized trial of 50 hospitals and their communities to a structured service that we're calling COMPASS, the Comprehensive Post-Acute Stroke Service, to a team that will include a neurologist, a nurse practitioner, a nurse, and their community services compared to whatever usual care is. We have a strong and heavy evaluation plan on usual care because we expect this is going to dramatically shift over the next 5 years. But all the same, we're really excited to be able to be leading this work forward out of the state of North Carolina. This was the model that we had originally proposed to CMS when they had called for bundled care proposals. But similarly, the reason why I pull it up is that we showed with just 300 patients, we would reduce costs by 34%. That was within 300 patients in one county with this model. And so we're really excited to now be able to do this in 25 of our intervention sites in North Carolina. What I also have learned, though, in doing this work is just because it may work here in North Carolina and works in Ohio, it's not going to work around the world. This perception of how we propose the continuum of care isn't global. Most countries don't have post-acute care the way we look at it here, and they don't use that term, and rehabilitation is either in the hospital or it doesn't exist. 2 trials that are happening similar to the one I just described to you here in North Carolina, one in India and one in China. I'm a co-investigator on the one in China, and it's shifting the concept of rehabilitation to family-led care. So training, training nurses in county hospitals in rural China by physicians and rehabilitation experts. And then really working with the patients and families. They have a longer length of stay, so working with those families prior to hospital discharge, teach back, goal setting, task-oriented training, and then following up with them in telephone visits, and then doing our outcomes assessment with a blinded researcher. So not so dissimilar from what we're doing here, but leveraging caregivers in both the India trial in India and the trial in China compared to conventional care. We got to a little bit of a rocky start. We've learned a lot in both countries, but what's interesting is being able to learn from these and how we might be able to test this in other places. Gaps remain. And for as long as I've been doing this work, I usually use the mind the gap perspective in the gap from hospital to home. This for me now, and especially in working with Chris is on our advisory board for PCORI, I'm reminded in how much we focus on still kind of the older adult, the one we don't expect to return to work, just being able to support basic needs. And being reminded that you had your stroke at 23 and how little we know about what we could do for people in best supporting self-management and restoring function. There's so much more work that we need to do. And this is where I think we're going to have the best opportunity for leveraging technology. We have, if you just consider stroke alone as just an example of the numbers, we could potentially be working with 3 of every 4 stroke patients, 600,000 people a year in this space and engaging them in some technology platform to be able to be promoting a stronger care plan than what we have right now, just in this country. There are a lot of options. And I'll briefly go through each of these. Hub and spoke models, remote participation in monitoring, and digital health. Ultimately, though, for improved outcomes, of course. The hub and spoke model, this is being tested, has been tested twice in this country. Helen Honig across the street, she's a geriatrician and had been trained as an occupational therapist, is working with a team out of the VA, where you essentially have a team of professionals at a local site, it happens to be the VA across the street, working with remote clinics, other hospitals, or even in patients' home. So you're delivering care directly to those sites remotely. So you have the experts in one place and you're delivering it to either a facilitated community level health worker or not, or family in their home. A second model, though, is this remote management model. So you can imagine someone leaving an inpatient setting, they go home and engage with potentially programs like designed in the Microsoft Connect box, something on your iPad. Being able to think about that these programs are essentially rehab programs, game-based systems, where they get feedback on the work that they're doing, and have this data go into a central location that's being monitored. They get feedback. It could be electronic, it could be by phone, and they're monitored over time. Their rehab plan could be extended, and we could be reaching people in places that we would never have otherwise reached. When you think about this at a population level, the number of people either going directly home or leaving a post-acute inpatient setting continue to get the care that they need in their home, leveraging the technology and being able to design the plan that best meets their needs. So these wouldn't be kind of a standard out of the box, but really being able to design it with the modules they need. And the programs that are being developed now include cognition, include communication, and include physical activities. What's been so interesting, though, is kind of this new space of apps. And I don't quite know what's next on the market. We've been so invested in kind of the engagement of rehabilitation and training, but do we always need to have this connected back to providers? How much of this can be self-led? When there isn't an app, we still need to think about the opportunity for text messaging. The trial that we just submitted to NIH to be done in China is a text-based trial. It's not stroke, it's going to be all comers leaving the hospital. But when you think about mobility impairments, just someone who may have been in the hospital and not reaching what's the goal at discharge, 200 feet? Is that what it is now to discharge patients, 200 feet before you can be discharged home? Just be independent. But ultimately being able to guide them through a mobility protocol and continue doing that through their cell phone, getting feedback from where they are, being able to essentially move them from bed level mobility, sitting at the edge of their bed, being able to stand and being able to walk, moving them through a mobility protocol. We can't do that in a 4-day length of stay, but we can continue to support them even through text messaging. I see all of these as complementary models, so I may be a little bit of an optimist in that, and I see them all coming together. I think it's important that we test them separately, but we need to move this space forward faster, and I see them all relating to each other. I also see that although we're doing a lot of this work in stroke, that this is not limited to stroke. The teams in geriatrics are very invested. We know that this applies to a lot of other patient populations and ultimately could have really broad impact. I also am reminded on days when this gets really hard that there are a lot of people, and the momentum here is really positive in being able to promote functional independence, especially after an acute hospitalization. Having now started working globally with some other countries, we've started to think about where we really should be investing our efforts. And so in the spirit of Gandhi, we're thinking about developing a global alliance to address aging and disabilities with healthcare innovation. I referenced a lot of studies and work that we have going on right now. I wanted to leave time for questions, and I didn't actually reference the funders as we were going through, so I list them here. But most importantly, I want to recognize the people I work with, and I couldn't fit them on a slide, and I think that was good, in that this isn't my work. This is a team sport. I got a really great email from somebody after the last grant came through and said, "Wow, you are a rock star." And I thought, you know what, I'm just part of a really good band. We have so many great people, not just here at Duke, but working across the country and in other countries who are just committed to this science. So I'm really thankful that I've had the chance to work with all of them. So thanks for being here.
wonderful overview of a very important problem and some important work that hopefully will help bridge many gaps. Questions from the audience?
Janet, that was great. Can you talk a little bit about the instrumental variables that you do? A little bit more about what you're doing with trying to sort out the confounding in your observational study, in your comparative effectiveness study?
I can, and I can even leverage the people in the room who helped teach me. And I understand that we've had some really great discussions with the fellows here as well in trying to best understand when to use them. So what we came to learn quickly, so I want to be able to unhide this, is that we ultimately wanted to look at we wanted to be able to understand causal relationships in a way that we can't in these observational data. Move back one. Here we go. We knew we know that there's only so much that we can capture in these data, and we know that there's a lot that we haven't been able to measure. To the best that we could, instrumental variables would be able to account for some of that unmeasured confounding, or so we had hoped. What I'm learning from my team is that it's never foolproof. And so even while we tested 2 different instrumental variables, we got different findings. In that we were more confident in the findings because we kind of were able to create this natural randomization using these 2 different instruments, but it still is not a perfect scenario. Jeff, did you want to add?
Summarize it bluntly.
No, please.
But I guess my question is, what were the instrumental variables?
We used 2. One was this hospital practice pattern, so the proportion of patients from a hospital that were discharged to one of our treatment groups. In this case, it was inpatient rehab. And so that was the first one. The second one we used is distance, the differential distance from where someone lives to where they would potentially have received care, differential between inpatient rehab and skilled nursing. So these are the 2 that we had tested. They mean different things, and trying to be able to communicate them practice patterns on how they're making a decision out of the hospital versus distance, which may actually be more patient and family centric, which is why we wanted to look at them both. You look like you still have a question.
That's good, thanks.
Dr. Peterson.
Yeah, no, thank you. I think that both sides of this were really great. I mean, again, Chris, thank you for coming. The concept of bringing a patient, or yourself, an individual, I think you'd probably say not a patient now, to explain what this meant to you is really important. And beginning with you in our minds is a very special and important part. I will only correct one thing that you said when you were going to the 52 and 53-year-olds and saying that was the old side. Yeah, I
had to be really careful with that.
Getting more sensitive. To Janet, I would say that it's fascinating to sort of watch your career develop. The idea of both using multiple different techniques to address one field, an important field that means a lot to patients, but both observational to looking at variations in care, to looking at best practices, to trying to implement best practices across the country, to doing technology assessment and developing new and novel practices, and then ultimately to apply them around the world. Pretty broad group of skill sets, but all important to try to address the one. The one I know you're thinking about, but you didn't address today, so I'll push you just even to complete the circle, is actually on policy. Because at the end of the day, you alluded a fair amount to the fact that unfortunately policy is a lot of the drivers of what happens. How reimbursement will in fact affect the degree to which patients have the opportunities to do this in this country, let alone opportunities to do it in other countries, let alone the development of new novel technologies. So you want to speak a little bit to where you feel policy might fit into this?
Fits into every part of it, I think. Related to the 3 major components, we started on this path on wanting to compare the effectiveness of the post-acute options for 2 reasons. One, payment was changing, good and bad. We hear bundled payments a lot, and thinking that providers may differentially choose one service or another without actually knowing which one's better for the patient, but because one of them costs less skilled nursing facility care costs so much less than inpatient rehab, and if a hospital chooses that path and it's not in the best interest of the patient, what that could actually be doing for that patient's family and the rest of their lives. So that ends up being the first one. The second one is still related to the comparative effectiveness research that we're doing, is that we saw such dramatic shifts in use of post-acute care, post-prospective payment. And we just had a paper in JAHA about kind of the trajectories of where this sat. And yet for stroke, it stayed kind of flat. There really weren't any changes in who used what. And we didn't yet understand why that was, except we kind of make these decisions more based on what's available than what people need. So in wanting to be able to direct these decisions based on outcomes was really important. Sharing this with policymakers, though, they ultimately want one answer. And so we need to do a really clear job of disseminating what we think works and for whom. And that would be that next step on policy. Related to the intervention work that we're doing, if you think just within the United States and not globally, we have very different rules around who can provide what care. In certain states, nurse practitioners can lead care teams and have prescribing privileges, and others they don't. In certain states, physical therapists can be sought out directly for care, in other states they don't. Thinking about what a multidisciplinary team would be and what's needed, we have a lot of workforce policies that need to be in place to actually best design care for post-hospitalization, not just for stroke, but for all patients. And I could go on that one, but I won't. The last one, policies related to telehealth, change every day, it seems, right now. And to the best that there's so many of us engaged in this space, the best that we can keep each other informed of how these are changing and how we can stay most up to date in being able to address those and test in that safe space, but push the field forward is going to be really important. So across all of these, policy ends up being important. I think my teams included, we just need to do a good job disseminating. Yeah.
Janet, great talk. I think clearly a very important area that we translates well into other spaces as well. I was struck by your last comment, and as we reflect kind of on our own practice about how the physician or other clinicians actually have input into the discharging decision in terms of where the patient's going. And I think often potentially we do, but we may not be as active in that space. So I think your idea of having this multidisciplinary team is really a critical one, and I wonder if you could assess that more prospectively and have a simple intervention to actually look at bringing a team-based approach such that it's not, at least when we see patients at Duke, it's often the PRMs and kind of PT, speech, and others that are really driving that, and it's not clinician-driven. So I'd be interested in your thoughts of how we move forward to try to look at this prospectively and inform patient management.
Yeah, a really great question, and Chris had alluded to that too. It's often the PT that drives, next setting of care. When we had done an open survey of hospitals in the Northeast of who they think, from a clinician perspective, who they think drives the discharge destination decision, and everybody thought it was themselves. The physicians thought that they had the biggest say in who went where. The nurses thought the case managers did. The case managers thought that they did as well. The patients said that they did. And so nobody was really acknowledging anybody else on the team. It was the opportunity for us to think about what discharge planning really could be. And in that space, we have spent so much time, so I'm only going to speak for stroke for 1 second. We've spent so much time thinking about core measures for stroke in the acute space. We haven't actually considered what is the appropriate discharge bundle and how the team needs to be engaged and what that looks like. And so some of that work we will be doing out of the pragmatic trial here, but in the next iteration of Coverdell funding with the 6 states that will receive funding for 5 years, that is a really big component, how to engage teams in the discharge process. So we hope to have more on that soon. It's just, it brings me to a great point. We did this systematic review on care transitions, and then we started to disseminate it. We thought we had these great findings of, there are huge gaps, only to find out that there are tons of people doing work in this space, but nobody's measuring it or disseminating it. There are hospitals all across the country trying to re-engineer discharge processes. They're not measuring it, and they're not disseminating it. So I think we just need to engage more people in the discussion and figure out how to either standardize it or evaluate what they're doing and see who's doing it best. Great question.
Chris, thank you very much for sharing your powerful leadership story, and to both of you, congratulations on a really fantastic program.
Thanks so much. Thanks for being here.